to Dr. Monika because she volunteered. Dr. Monika Gupta is one of the pioneer surgical gastroenterologists in the city of Jaipur, and she has a fairly large experience with management of trauma. Monika, can you please come in?
So, Dr. Santosh has covered a lot of issues in trauma, and I think trauma is like that. Everything, everywhere can be getting involved in various ways, maybe in a blunt way, or a penetrating way, or a sharp way. So, I also wanted this type of coverage for a trauma webinar, and I think throughout the both of the days, we have covered various issues. Only a few points, practical points, I like to add, because the hospital where I work has been initially started as a trauma center by the government, and later on it has been a full-fledged corporate hospital. So there are few issues which are differently managed in a private setup, right? So that is the main message I want to convey. Particularly, more cases come to us with mesenteric trauma, although they constitute only 10% of the trauma cases. In children, more are solid organ injuries, more than 50% are solid organ injuries. But for the surgical cases, more are mesenteric trauma. 90 to 95% of the liver injuries which we have encountered have been managed conservatively. And splenic injuries probably has been managed mostly conservatively. Only a few have been operated. In fact, a atraumatic splenic hematoma or a splenic bleed can also be present in some few medical variety of the cases where you need to differentiate from the traumatic splenic injury. Regarding the ER management of the trauma, various issues have been discussed like this FAST and DPL and all those things. But I think CT stands the test of the time. In ER, first of the thing we have to do is to streamline the process of getting the imaging fast. In stable or a patient who can be made stable, CT is required, and CT can be done very fast. Maybe in 30 minutes, we can get the CT films and imaging on our phones, even at the midnight hours. So that thing, every ER should streamline. What we do is, as the patient comes, our ER doctor does a VBG or ABG of the patient so that he gets a creatinine. And after getting the creatinine and stabilizing the patient in the meanwhile, if the patient is stable or already stable, then patient can be sent to CT. And obviously, as they have already said, that oral contrast needs to be avoided. Most of the times, we don't do any oral contrast CTs these days. If any case needed in elective setting, only negative contrast CT will be done. But positive oral contrast is nowadays, I think we skip it. Only IV contrast we advise after getting the creatinine. And if the creatinine is high, then we can get a consent sign or explain that there can be an renal issues, but CT is essential. So CT scan gives lot of information about amount of hemoperitoneum, about the number of injuries, solid organ, as well as the pneumoperitoneum. Now here, if we have a stable patient and a sonography has been done, solid organs have been ruled out, there a plain CT scan can also be useful. A plain CT with a good radiologist reading down at their home screen or a hospital screen, but reading about the pneumoperitoneum. And finding very small specks of the air is also important. So at the midnight hour also, we keep one of the radiologists on call who reads these CTs on the phone. Although there is a rider that it may not be very accurate, and there is a rider then in the morning, some part of the reporting can change. But most of the times they are, I will say 90% times, they are very helpful, because in the early morning hours, we can operate those patients. In the midnight, we can operate those patients for the mesenteric as well as small bowel injuries. And it is very useful to do a plain CT also in the penetrating injury. Like we were discussing about the local wound exploration to find the peritoneal bleach, my approach will be doing a plain CT abdomen to find a small air speck in the peritoneum. So that air will guide me whether peritoneum has been breached or not. So if peritoneum has been breached, then penetrating wound can undergo laparoscopy or as well as open. And this is, I think I have started practically also, that in a very small injury where we are hardly suspecting any solid organ injury. But because of the medico-legal importance of the offering the surgery to penetrating wound, because it has been trend that if there is a penetrating wound, surgery should be offered. I don't know if we don't do any surgery and in any case later on patient turns out to have some gut injury, what will be the medical legal significance, which should also be discussed in some later time or some sessions later. So in laparoscopy, we can find out whether there has been any blood or any other gut injuries. Gut can be explored in a milder form of penetrating wounds. And in case of major form of penetrating wounds, open surgery is desirable because sometimes they can mislead us and sometimes we may think that no, there may not be. Recently, I have operated one young male where there was an 4 or 5 centimeter size of penetrating wound in abdomen. I was biased. Actually, I was biased and I was confused with whether to do go lap or open. But when I opened from the lower midline and the injury was on the stomach. Penetrating wound was on a left iliac fossa. So these can be the scenarios in the penetrating wounds. Gunshot, I think, is a totally different topic, and I think it can be discussed in one more separate session. And regarding the retroperitoneal hematoma, I get a bit worried about retroperitoneal hematoma when it comes with mesenteric trauma. Because retroperitoneal hematoma, when it gets opened or when we open it up, it can keep bleeding because the source can be pelvis, the source can be retroperitoneal structures. So either we need to confirm that the hematoma or a bleed has been stopped properly before we close the abdomen. Otherwise, post-op blood may be a problem in the post-op scenarios. And in case of trauma, one strange case I like to quote in the end. I don't know how people find it easy to get injured in similar way many times. So one patient we got in last 6 months who was already operated for trauma, a big midline scar, who had got the stoma made, stoma got reversed. And later on also with us also, he landed up with abdominal trauma, same. We made the stoma and we reversed the stoma. So these strange scenarios can be there. So definitely, sir, this session is very useful and I hand it over to you for the further comments.
Thank you, Dr. Monika. I think we are nearing 9, so I would give last couple of minutes to Dr. Sastry. But Kishore also has said the same thing, that CT in a hemodynamically stable patient, even if there is an indication for laparotomy, is a useful adjunct, because it makes you better prepared. Dr. Sitaram has made some comments which are mainly what Dr. Sastry said, that for pancreatic injury, we are moving more and more towards a non-operative, and even if it is operative, more conservative management. Dr. Sastry, last few comments before we close.
I think we had quite a extensive discussion, particularly of penetrating injuries of the abdomen. Pancreas, I think we have already discussed, and there are changing trends, and how difficult it is sometimes to diagnose a pancreatic injury, and how imaging is the mainstay of investigation. Grading and the proper fallacies of grading, the newer gradings are also discussed, and the role of interventions, particularly in more severe injuries, grade 3 and grade 4 injuries. Grade 5 injuries, whatever you do is a bad situation. So a damage control situation is the only methods are the only recommendations, whereas in grade 3 and 4, where the ductal injuries are there, the right or left, and see how best we can conserve the pancreas and do enough drainage and debridement. If for left side resection, pancreatic resection, avoiding anastomosis. I think that would be the pancreatic take-home messages. Whereas in the penetrating injury, I think it is too extensively discussed. I think I only just wanted to add, as Dr. Monika was saying, laparoscopy in where peritoneum is breached in the penetrating injury, but the patient is absolutely stable and the abdomen doesn't show any clinical signs. I think definitely a laparoscopy would be quite useful. Also in thoracoabdominal injuries, where you want to see the diaphragmatic injuries, they are the ones which are generally missed, and they are best diagnosed with laparoscopy. I think That's about all. I'm sure we can go on and on. There are a lot of areas where you can have a difference of opinion, discussion, and evaluation of these things. And definitely, things are evolving. From the days when we thought, say, we were taught that a penetrating injury always requires surgery. Any penetrating injury, you must operate. To a guarded selection of patients for surgery in these injuries. I think with these comments, I hand over to Dr. Kapoor for the final, if any.
There are two questions from Dr. Vihar Kotecha, but Vihar is a regular attendee, so maybe we will take his questions in some other session. There is a note from Dr. Marcos Chahin from Dominican Republic, but he's just put his name. He hasn't put any question. I'll request Dr. Marcos to please send a WhatsApp message to Dr. Nagar so that we can add you to the online portal. So with that, I would like to thank TD. You want to make some comment quick? 1 minute.
Sir, I think it was very extensive topic, and but Dr. Santosh has to because penetrating starts from chest, back, anterior, posterior, and all abdomen, anterior, posterior flanks, and I think lots of discussion has been done, and seniors, all of you have made already comments, so I don't think. Only thing I can one say that when we are doing a distal pancreatectomy and come to the right side of the SMB and portal vein, definitely we are finding diabetes. So it's not that we remove about so much of pancreas and there won't be diabetes. So one has to be very, very careful when one needs so much of pancreas to be sacrificed. So that is all I can say. Thank you, sir.
Okay, so I would like to thank all the speakers, Dr. Sastry as moderator and Dr. Sitaram for again being present. Thank you very much, everyone, and see you in the next masterclass next month. Thank you. Bye.
Thank you, sir. Good night,
Thank
sir.
you.